All right, we're going to talk about another polyoma virus here. We're now going to talk about BK virus. BK virus should remind you of JC virus. JC virus we talked about in your multiple sclerosis case in your M1 year in the brain and behavior block. Like JC virus, BK viruses are found ubiquitously in humans, but they don't usually cause disease unless the patient becomes immunocompromised. So when a patient becomes immunocompromised, then we can see kind of reactivation of the virus, which can then lead to disease. These viruses are very difficult to grow in culture. There are also a lot of other important polyoma viruses. Some other ones are things like KI, WU, and Merkel cell, which I'm not talking about here, but they are also polyoma viruses. Okay, so we're going to just do a review of polyoma virus structure and replication before moving on to the clinical syndromes, because, well, it's been a little bit. Okay, so first off, like I mentioned, this is a polyoma virus. The other polyoma viruses that you might be familiar with are things like JC virus. These are very small viruses. They're about 45 nanometers in diameter, and they have about 5,000 base pairs. Their genomes are divided into early, late, and non-coding regions. The early region has one strand which codes for non-structural T or transformation proteins. So this includes things like large T, T prime, and small t antigens. Now, when we think about this, remember when we were thinking about JC virus, you could actually do tests for the T antigens in the tissue, which would be one way of differentiating what looks like a glioblastoma into the JC virus pathology that we see. Okay, so now the late proteins, the late region actually encodes for viral capsid proteins, specifically VP1, VP2, and VP3. Then you have these non-coding regions. These contain the origin of DNA replication, transcriptional control sequences for both early and late genes. Replication of polyoma viruses are highly dependent on host cell factors. And that's why when a patient becomes immunocompromised, we actually see a difference in how the organism is replicating. So a permissive cell will allow the transcription of late viral messenger RNA and viral replication. When that happens, the cell dies. The virus then could also establish latency in non-permissive cells. So permissive cells will die, but non-permissive cells is where the virus establishes its latency pool. When it tries to replicate, it's blocked by immune cells. But therefore, when you have a T-cell deficient patient, like a patient with HIV or AIDS or a transplant patient, we can see a reactivation of the virus. And the place we see this reactivation of the virus the most is in the kidney. So let's kind of talk about how this happens. So how patients get infected is still somewhat up in the air. But as I mentioned before, these are ubiquitous. Most people are infected by about 15 years of age. And the virus basically is spread in urine, feces, and potentially respiratory, so like aerosols. What happens is you get infected and then you get replication in the oral GI or upper respiratory tract. This is going to lead to a primary viremia, which basically allows the virus to go systemic and look for permissive and non-permissive host cells. Both are good, right? Because permissive, it gets to replicate in lice. Non-permissive, it at least has a foothold, okay? You're going to see multiplication in the kidney. Now, in the kidney, when we see multiplication, we actually can, that's when eventually you might see infection, but that'll be later because the primary infection is asymptomatic. Later, you might get a transient secondary viremia. If the patient is immunocompetent, I don't know why I couldn't read that word, the patient will be latently infected in the kidney indefinitely. Okay, so it's just in there, but immune cells are blocking its replication. Should the patient become immunosuppressed, that's where we see reactivation of BK multiplication within the urinary tract. And then we can see things like viuria, which is basically just virus in the urine, or even things like hemorrhagic cystitis. We see ureteral stenosis in renal transplant recipients. And then we also can see hemorrhagic cystitis even in patients with like bone marrow transplant recipients. So it's not that we're just immunocompromising that area like we did in JC virus. It's really just when a patient is immunocompromised systemically. Cytologic tests might reveal the presence of the BK virus infection. And then you might also see kind of these enlarged cells with dense basophilic intranuclear inclusions, which kind of resemble what we see in CMV. That's kind of its cytopathic effect. And it's really difficult to isolate BK virus in cultures, so that's not really done for diagnosis.